Welcome to the New to Medicare Payment Methods webinar. This webinar is for information for fee-for-service Medicare payments. My goal is to meet the needs of everyone asking those pre-submitted questions that we gathered, and then any questions during the event. We want to cover as much information as we can. I'm Tom Ryan with Provider Outreach Education. I'll be your presenter. Today, I'm joined by Aline from my team, and she's here to help me with those questions that you're going to post into the chat, because you're going to want to make sure that you do that should you have any questions that arise. A little bit of housekeeping for today. First, if you would like this presentation, please move to our training center and download the material. It is available on our live events page. I did have Aline put that into the chat for you. Also, if you want to register for any upcoming events, that's where you're going to do that. A couple of questions came in about how do you get the presentation later, or what if someone wants to review it. We are recording this presentation. We will make it into an encore presentation that will be available on our website. Along with that encore presentation recording, we actually will repost the PowerPoint. So you will see the PowerPoint go down later today or tomorrow morning, but then it will be reposted when we post the encore presentation. That may take a week or two, but usually it's done within 14 days. Again, if you have a question, please take time to grab those questions, put them into the chat. You can do it at any time that I'm talking. I do have various points built in to kind of help get those questions answered. If Aline says something really important, or if she feels like might need to be addressed right away to stop with confusion, she can stop me at any point and do that. So please keep that in mind. Also, we are going to give you a survey. Now, it's really important with the New to Medicare, as well as with any education, that you take the survey. With New to Medicare, though, it's important so that we make sure we're meeting your needs. For those of you that are new to Medicare or with under 6 months of experience, we want to make sure that we cover all the information we can get you. It does take approximately 12 different webinars, or in other words, a full year for us to get through all the information, but we want to make sure we meet your needs. Also, in that survey, you'll be able to ask any questions that you have, give us comments. The comments are great in that we can look and say, hey, what type of education are you looking for? What did we do well? What did we need to improve on? All of those types of things. So again, I'm going to encourage you to take that survey a little bit later on, but I wanted to talk about it now so you're aware of it up front. Disclaimer. So basic things to keep in mind. This information was put together and it was current at the time we put it together. It is given a date on the front title slide. The information, though, can change from Medicare. Many of you are not new and are looking as a review to this course may be familiar with the changes and how they occur. Changes have occurred very frequently, and some changes rarely occur. So some items don't change at all and others change frequently. With that said, any answers that we give during this education today are based on current facts, regulations, rules, all of that type of thing. If you want to know where those facts, regulations, and rules are, I will reference various things to the CMS website. That is the official website for providers and claims processors, the Medicare administrative contractors, to use. Okay. Now we're going to talk a little bit about another website, and I'll show that to you in a little while, more or less because it's the patient's website. And so that's going to be a different website, but we'll get into that. So when you are talking about accessing current information, please make sure you access cms.gov. What are we going to talk about today? Well, it is to help you understand the different payment methods and how they affect providers. Now, a lot of people say, but I only get paid in a certain method, or this is what affects me. What do I need to know all this other stuff for? And that's what we're going to cover. The other stuff or the other payment methods can actually affect who you have to bill. So that becomes even more important to understand. We do want to give you just some basics. Now, the basics were built in to answer a variety of questions. Some of those questions were simple things like, can we bill in a claim form? Well, yes, you can bill in a paper claim form. We'll talk about that. So again, we're going to go back and forth with some of those payment basics. We're then going to talk about the types of payment methods. What are the ways in which Medicare can pay, and which one do they use for the items you need to know? Now, remember, just because you're not paid under a certain payment method, you might want to pay attention. It might affect your payments, even though it's not how you're paid. And I'll explain that as we go through. The last thing we definitely want to do is to give you some resources. A lot of the resources I'll actually cover as we go through. So don't be surprised if when we get to the resources, I'm like, oh, we've already talked about this. We've already done that. But I wanted you to at least be aware that I'm going to give them to you. So let's start with the building blocks or the basics of payment methods and why it's important to understand certain things, okay? So when we reviewed information and questions, one of the things we were asked is to cover who this material applies to, which is what this, this slide was built for. This material applies to traditional Medicare, fee-for-service Medicare. That is Medicare Part A and B. That is not Medicare Part C or Medicare Part D. Medicare Part C is Medicare Advantage and Medicare Part D is prescription drug coverage. Traditional Medicare was the first form of Medicare put into play, and it was established in federal rules, which then are translated into the fee schedules. So they look at a variety of factors in the fee schedules. They also have certain prospective payment systems, which again will explain what these are, that translate into certain payment methods. These are what are used during the claims processing portion for traditional Medicare. Regardless of how a claim is processed or regardless of what payment method we use, you will be given an approved amount, and there will be patient liability assigned when necessary. The question that came in about patient liability is what does not have patient liability? And an example of that would be a preventive service. There's no patient liability assigned to that. There are other types of services that do not have copays, coinsurances, and do not apply to the deductible, which are the patient liabilities, but we'll talk more about that as we go through. The next question that came in with traditional Part A and B Medicare is the patient liability the same? I'm assuming you mean the same under all of the different methods of payment, and the answer is no. So for instance, inpatient and outpatient have different patient liabilities. They're under different benefit categories. So we'll talk a little bit more about that as we get through a variety of different things. One thing I do want to point out with traditional Medicare, when you're talking about Part A and B Medicare, it is processed in a couple of different places. The Medicare Administrative Contractor, or MAC, for your state processes the most claims. However, there's another MAC, and it's called the Railroad MAC, or RRB MAC. They process claims specifically, or they process claims for people specifically designated eligible for Medicare under the Railroad Retirement Benefits. And so if you look at your screen, the upper left corner, you're going to see, or I'm sorry, the upper picture, you'll see nothing in the bottom little red bar. And in the second one, the lower picture, you'll actually see where it says Railroad Retirement Board. That's the first rule you need to be aware of. While we use the same payment methods, we do process claims differently. It's different contractors. So if you see Railroad Retirement Board, that is not WPS. It's also not a Part C plan. The Part C plan is the next item I want to talk about because I got quite a few questions on this. So first of all, a Part C plan is a Medicare Advantage plan. They are not the same as original Medicare. Instead, they're a separate plan under a separate contract with the Center for Medicare and Medicaid Services. This means their reimbursement is unique to their plan. We at WPS are not a Part C plan. We do not administer one. We cannot talk about them. Again, we will talk about traditional Medicare Part A and B. Along with Part C plans, they can incorporate Part D coverage, which is prescription drug coverage. We also do not do that either. So this presentation today is only for traditional Medicare Part A and B. Now, please keep in mind that when you're talking about a Part C plan, you have to follow their information and their information that's available. Their payment methodologies can be different because that's part of what the plan is contracted to do. So you may need to contact that plan. Let's talk a little bit about payment considerations. And I do want to back up just for a second here and kind of explain a little bit about the history. So when the Medicare program was first implemented, we were paid a fee basis on the actual cost of the services and the supplies. So each office visit, test, or procedure they did was paid on a fee basis. They sent in information, and these were the providers, and then they were paid. Providers were paid on the basis of the actual cost for providing a services, not on a fee schedule, not on a prospective payment system, nothing like that. So for example, a hospital submitted an annual report. It was called a cost report, which itemized expenses for the hospital's prior accounting year or fiscal year. Some providers received a certain amount per day, called a per diem, for each day a patient was inpatient at their facility. Again, rates were then based on historics, actual using the cost of that facility and adjusted down or up each year. Medicare experienced a very dramatic increase in the program during the first 15 years of operation. Well, what increased? And that was the cost of the program. As more and more people began to use it and we were paying based on these fees, Congress said, we need to do a little bit something else. We need to reevaluate how we're paying. So what Congress did was to look at reimbursing for services while at the same time encouraging providers to deliver care more efficiently. In other words, hey, we're really going to look at what you're doing and how can we cut the costs, but at the same time reimbursing you for what you did. This is where the different payment methods came from. So before Medicare can even consider reimbursing, we have to make sure that it meets a benefit category. These are part of the Social Security Act, and then they're defined in the Code of Federal Regulations. And last, they're put into daily operating manuals. This is the Internet-Only Manuals. So there's a lot of things that go in just to make sure it's a benefit. Then we have to make sure it's not it's not specifically excluded from coverage. And that's a separate section of the Social Security Act, and that's a separate title. And so we also have some different areas of that. Then under the Social Security Act, we have to make sure it falls into the reasonable and necessary section, which is medical necessity, and that's section 1862A1A. For those of you that are not familiar with that, with what's going on here, if you click on any of these, it will open up a variety of different factors and things you have to be aware of. So if I were to click on the bottom one, it will open up my website. And by the way, I just used the verbiage section, Social Security Act, section 1862. Then I get this brought in and I read, okay, here's A, notwithstanding, which is why we say all the other provisions. Then you go, so that's A, then you go 1A, which excludes items and services described as not reasonable and necessary. So this is what we have to use as our basis, but then we also have to consider everything else. Everything else. So what Medicare does is the Center for Medicare and Medicaid Services on their website takes all of that information and puts it into what is called Internet-Only Manuals or Daily Operating Instructions. So the website for that is cms.gov. We're going to go to Regulations and Guidance. We're going to go to Manuals. Remember, I called them Internet-Only Manuals. Again, Daily Operating Instructions. Then once we're inside Manuals, we're going to go to the Internet-Only Manuals, which is the first item on the left. And we're going to scroll down a little bit. You can see a lot of different manuals in here, and they do have to meet the different components, and a lot of these are based in different sections of the Social Security Act. The one that I want to focus on right now is 100.02, which is the Medicare Benefit Policy Manual. This is your general information, and entitlement manual is 100.01. Great information, but it really is going to talk a little bit about it. 100.02, when you scroll down, it covers all of these different payment methods and how we have to look at things, what we have to have. And so that's why I want to focus on it. This is where a lot of our information is going to come from and what we're doing here, even down to the point that there's an exclusions manual within this. So if it's within this exclusions manual, we're not going to pay it. So I wanted to bring you guys out here and make you aware of that. Hopefully that answers the questions a little bit about why we pay the way that we do. It is a cost savings for both the Medicare program and the patient. The determination is whether it's medically necessary and it's not specifically excluded. So those are items that we look at. From there, Medicare uses two systems to pay claims under traditional Medicare. Now remember, I said Part C, they have their own system, they do their own thing. We aren't going to talk about those systems. What we're going to focus on is the two systems that Medicare uses under traditional Medicare, which is A and B. The first one is the Physical Intermediary Standard System, or FIS. This system processes both benefit categories. Part A benefits, inpatient, and Part B benefits, outpatient, that the catches for facilities and for other certain payment systems. So, for instance, a rural health clinic would have a certain payment methodology falling under here. When you go to bill these claims, if you bill on an 837I electronic transaction or electronic claim, you bill to FIS. If you bill on a UB04 paper claim, you bill to FIS. Now again, it's the Physical Intermediary Standard System. Some people say shared, and that's fine also. So it's really about the way in which you bill. It's a line of business is how Medicare refers to that. On the other hand, the second system is the multi-carrier system. The multi-carrier system only processes services falling under the Part B benefit category. All services must be billed electronically on the 837P or in paper on the CMS 1500 claim form. So yes, we do still accept paper claim forms. That was a question that was asked. However, I'll give you a little bit more information when we get to the question and answer section, because I'll give you the actual reference for what you have to do to get a paper claim form in. So when we're talking about payment methods, each one is built into a certain system. So for instance, the fee schedules are built into the multi-carrier system, where the prospective payment systems are built into FIS. So it's really how they're paid. And we'll talk more about that. Don't think that one is necessarily different than the other, but we will talk more about that. Okay, things to keep in mind when you go to enroll and you're enrolling into either system, okay? You have to submit an electronic funds transfer agreement, because Medicare will only pay you electronically. Now, this is in the publication that we talked about, and it's in the Medicare claims processing, which we didn't look at, but it is in Medicare claims processing, and it's in chapter 24, which is an electronic submission, and it's Electronic Funds Transfer or Administrative Simplification Compliance Act. It's the requirement that goes with that. We'll talk more about that. But the question is, are you required, or do you need to submit this agreement to get money electronically? And the answer is yes. It's part of the claims processing that you have to be aware of. It doesn't matter which payment method you fall under, we do have to pay you electronically. The other question that came in is they were talking about getting certain payments without the electronic transfer, and those are special payments. Sometimes there are things like health professional shortage areas, or like just shortage areas in general. So there's certain types of payments that could be still issued via check, but for the most part, we do pay you for claims electronically. All right, so when we talk about Medicare and we're talking about traditional fee-for-service, a little bit of the basics here. We do offer 3 different base methods. One is fee schedules. These are maximum allowed amounts as set by Congress based on a formula. Now, Congress doesn't go out and say it's $20, it's $30. What they do is they set a formula. That formula is then used to establish how much the fee schedule changes each year. So it has a variety of different components. There is also a prospective payment system, or a PPS. This method of reimbursement is where Medicare bases it on a predetermined or a fixed amount. The payment amount for a particular service is derived based on the classification system of that service. In other words, a diagnostic-related group for inpatient hospital services. Now, that's inpatient acute care hospital. Could also be a skilled nursing facility or a home health agency, a hospice. They all have different prospective payment systems. Want to point out that when you talk about acute care hospital, inpatient and outpatient have separate prospective payment systems. Okay, so wow, we're getting into a lot of different payment systems, and we're going to go through just some basic information on all of those different payment systems. The last one is what is called reasonable cost. And this is actually a payment based on the actual cost. This means that we determine the cost for inpatient and outpatient services, and then we share those costs allocated to the Medicare program. So we'll look at that with certain types of payment methodologies. The one to kind of think in mind, or that most people are familiar with, is critical access hospitals. They're paid on a reasonable cost base, but more to come on that. Which brings us, once we introduce those basics, to the first question and answer session. And again, I want to reiterate this, and I'm going to ask Aline to actually put a link down in the chat here for me. But one of the questions is, do you have the old-fashioned paper forms? So first, we don't send them out. We don't mail them out, but yes, we accept them. So you have to find a vendor that uses them. Second, yes, they have to be some people call it pink and white. Some people call it the red and white paper, whatever you want to do. No facsimiles, no copies, nothing like that. If you're going to send us a paper form, we have to have it. The catch is, though you can use them, there are exceptions that allow this, because remember, the Administrative Simplification Compliance Act requires most providers to submit electronically. Now, there are some small provider exceptions. There are some, hey, my system's not working exceptions. Those exceptions are located in the Medicare Claims Processing Manual. They're in Chapter 24, and they're in Section 90.2. I had Aline actually put a link out there for you so you can take a look at those. What I'm going to do now is just, again, I'm going to run you out. I'll show those to you real quick. Again, we're in 100, which is 100.02 right now, which is the Benefits Manual. We need to go to the Claims Processing Manual, so it's 100.04. When we scroll down, you got to scroll way towards the bottom because it was Chapter 24. And there you can see it's the general EDI, which is electronic data interchange. Again, that's what we typically accept our claims through. And then when we go into the electronic data interchange area, we are actually going to, oops, that got a little bit big, sorry. We're actually going to scroll a little bit down here. And the section that we're looking for is 90.2, which is mandatory electronic claim submission of Medicare claims and the exceptions. Okay. So hopefully that will help tell you whether or not you meet the exceptions. I do recommend you read through them. If you have questions after you've read through the exceptions, then contact customer service and they'll help you with anything more that you need. Aline, do we have any other questions in the chat at this time?
No, Tom, we don't have any questions at this time.
Okay, let's go ahead and head right into the payment methods. Now, this is where we're going to talk about the fee schedules, which types of services are paid to what, where they could potentially bundle a variety of things. I'm going to go in alphabetical order, so if you're wondering where I got my order, it's just alphabetical. The first one is ambulance. This is a fee schedule. It's a set amount determined under the law, and what it does is it gives you a uniform pricing for ground and air, and then it takes into account things like where are you located, your geographical area, so there's adjustments for that. It gives you a base rate, and the base rate is for all items and services with the exception of mileage. Mileage is a separately billable code. So what falls into your base rate? Things like supplies, staff, the vehicle, all of those types of items fall into the base rate. You're not paid separately for any of that. We also have adjustments for emergent and non-emergent. It just depends on the level that you're performing because it is divided into various levels. So for instance, ambulance fee schedule for ground is basic, emergent, non-emergent, advanced life support level 1, emergent, non-emergent, advanced life support level 2, which is always emergent, or specialty care transport, always emergent. Then they also have air, and air isn't broken out by emergent and non-emergent. Air is broken out by the type of aircraft used, whether it's a fixed wing or a rotary wing or a helicopter. So that's how air is kind of broken out. But each one will have a specific base rate that incorporates the basic things, and then again, the adjustment for the mileage or the second billable code for the mileage. The geographic adjustments can occur, and the reason that that happens is it may cost you more to do business in Michigan versus Iowa, just as an example. So there's geographic adjustment like that. There's a national uniform rate for loaded mileage. We talked about that. But then there's also an adjustment done, and it's called a rural adjustment, and it's for the point of pickup in certain zip codes. These are defined by the federal government, and what it looks at is it rural, super rural, or urban, and you can do an adjustment based on that, and depending on where you're picking them up, how long it's going to take. It figures into a variety of factors. So for ambulance, you are really looking at a fee schedule that is established by Congress. We don't get a lot of choice in that, but it's also packaged. Okay. Now, the ambulance fee schedule will be overridden should the patient be inpatient in a facility, and we'll talk more about that because an ambulance claim could be billed to a facility. When it's overridden, it is not then separately payable under the fee schedule. So it's a kind of a Part A reimbursement method, but we'll talk more about that package or that bundle. Ambulatory surgery center. This is its own separate fee schedule, and it's done that way because an ambulatory surgery center can only do certain surgeries. They can only do a certain number of surgeries in a day, otherwise it can be unsafe for the patient. And so when they look at it, we're really looking at outpatients, and it's the surgical supplies and procedures, including the facility services. Please note, it is not some of the professional surgeon services, right? That's a separate fee schedule, and we'll get into that in a little while. The ambulance surgery, the ASC is about the surgical procedures. What can they do safely there? Okay. So when we look at that, they are given separate reimbursement, but only if allowed by CMS. So they have a list on the CMS website that says this is what can be performed in an ASC. Let's talk a little bit more about the next fee schedule, and that's the clinical lab fee schedule. Aline, can you still hear me?
Yes, I can.
Okay. Sorry, everybody. I had a computer blink, and I'm not sure what that meant, and it said my microphone went away, so I want to make sure you guys can still hear me. So anyway, the next fee schedule is the clinical laboratory fee schedule. This one is very specific, and it's only for clinical laboratory services, and it's only for things paid on that. It does not incorporate most professional services, except for venipuncture. Venipuncture is part of the clinical laboratory fee schedule. And so what it does is it weights the median for private payer rates based on the data collected and reported to CMS. It's updated every 3 years. So this one is not done yearly. It's not a yearly update. This is a 3-year update. And so then they look at it and they say, okay, this is what a clinical gets based on the overall everything going on. I also want you to notice the clinical laboratory fee schedule does not have a geographic adjustment. It's one of the few times when you will not see that incorporated. So the way that the fee schedule is set up is because of the weighting, it's a national fee schedule versus a geographic fee schedule. So if something falls under this fee schedule, again, venipuncture, it does not fall under the Medicare professional services or the physician fee schedule. And I wanted to make that very clear because that was a question. The physician fee schedule is the primary fee schedule for a lot of services. And it's not just physician services, it's a lot of professional services. This could include things like mental health counselors. It could include your social workers. It could include a lot of your PT, OT, physical therapy, occupational therapy, or speech language pathology services. So this is a much bigger fee schedule than just quote unquote physicians. And so I want to make that clear when people are going out to look at the physician fee schedule. There's a lot that goes into it. Someone did ask us specifically about Incident 2 and where that falls into it. Incident 2 is a concept that is usually done in an office setting, and therefore it's under the physician fee schedule, and that's how we base it. So depending on who's doing it, there can also be professional adjustments. What does that mean? So for instance, a physician may get paid more than a non-physician practitioner. So they're going to get paid a full fee schedule versus 85%. Those are types of adjustments that can occur under the professional services under the physician fee schedule. So the physician fee schedule has a lot of information that goes into it. Now, some providers and certain diagnostic tests that will be underneath here as well. Radiology services with that, that professional component may fall underneath here. So there's a lot of different types of services that will fall underneath this particular one. Okay, so let's talk a little bit more about the physician fee schedule. So first of all, the physician fee schedule has its own set of bundling rules. Some of you may or may not be familiar with them, but they are global surgery rules. That's one concept. Now, if you don't do surgeries, this one probably won't apply to you. But here's the thing. If you are a surgeon, there are certain things that have to be done in order to perform the surgery, and therefore they become a package deal. The package deal falls then into the global surgery package. They do use a variety of different indicators on the physician fee schedule on the relative value files to help you with that. So if you want more information, we do offer different classes on that. The physician fee schedule itself also has the Correct Coding Initiative, or NCCI, the National Correct Coding Initiative. This is a set of edits that promote correct coding. It's broken into 3 categories. 1, add-on codes. Add-on codes are defined in the guidings from CPT, so you have to build this to build this, add-on codes. The National Correct Coding Initiative takes those and and puts them into the coding systems or codifies them. They also have something called medically unlikely edits, and it's a set of codes that says, well, we really shouldn't be seeing more than 2, 3, 5, whatever the edit is. And the goal is then to say, okay, if you're doing more than that, you have to tell us why. Why is it medically necessary? That's a medically unlikely edit. What is the most we should see it for that type? But also along with that, they have procedure to procedure edits that say we should pay this versus this. In other words, if you build this procedure, you have to do these steps to build that procedure. These are the components of the bigger picture. Or if you're billing a virtual colonoscopy and an actual manual colonoscopy, why are you billing both of them? What are you getting differently? So now you have to show us why it's medically necessary. There are also certain services that Medicare says under the physician fee schedule are just bundled, period. And an example of that is when you're doing physical therapy, your cold pack or hot pack, they're automatically bundled. You don't get extra payment for them. It's part of the therapy service, even if that's the only thing you do that day. So I want you to keep that in mind, that the fee schedule has a lot of different bundling in and of itself. Then there's also something else that goes with this, which makes it effective based on your area where you're practicing. And the affected amounts, the dollar amount, is actually adjusted based on your geographic area. So for instance, if you were in certain areas, you will get more money than others. Well, think about that logically, and let's use an example. If you're in Detroit, Michigan, you're probably going to get more money than if you're in the UP of Michigan. Still the same state, nothing different there. It's just where are you physically located and which one has a higher practice. So that's the geographical adjustment. Then the fee schedule also says, okay, we're going to give you a percentage of amount that is a work amount, a service location amount, and a malpractice amount. And these are called the RVUs, or the relative value units. When all magically meshed together, they make the dollar amount. So there is a formula that CMS does use. It is available to you on the website. Last, they say, wait, we're going to give you an additional amount for the health professional shortage area, or HPS adjustments. These are the ones that you still sometimes get paper checks for, because they're a special payment, they're an adjustment, they're not part of your regular payment. So hopefully all of that makes sense when we talk about the physician fee schedule. Again, a lot more going into that. The next one is actually for outpatient dialysis, and it's the end-stage renal disease prospective payment system. We'll talk more about some of the adjustments and things that can happen, but let's just go through some base information. So the one thing about a prospective payment system is that it does one payment per the dialysis treatment. So in this case, it's one payment per dialysis treatment. It could be one payment based on a diagnosis or a variety of other things, but the prospective payment system allows for one payment. When they look at that, in this case, it's end-stage renal disease. What are they looking for? Any drugs, any lab services, any supplies, or capital-related services, which is the cost to furnish maintenance dialysis. Your buildings, all your supplies, other things that are incorporated that are still part of that capital related. So when the end-stage renal disease prospective payment system comes into play, it says, okay, this is how much it should cost you per patient per day. Here's your average rate. We're good. Okay. But then they go on further with CMS and say, hey, we're not quite done. We're going to give you some adjustments. One, depending on the patient's age, the body surface, the body mass index, comorbidities, facilities with low volume of dialysis treatment, and facilities in rural area, these are all things that can adjust your prospective payment system up or down, okay, mostly up. Also, what happens with the additional payments that you would get? So training, you're getting paid to do additional training. There is an amount that can be given for that. If a patient has a variety of different things going on or makes them a high cost outlier, in other words, this is our normal amount, but this patient has so much going on that it's actually costing us X amount more, they can get additional funds for that under the prospective payment system for the ESRD. Also, new drugs. Because when the drug first comes in, it's not necessarily priced in the same manner. So some of those new drugs do get additional payments until they get everything reestablished and set up. Hopefully all that makes sense. That's end-stage renal disease. The next one is the Federally Qualified Health Center, or FQHC. This is another prospective payment system, and this is based on a patient encounter. It's an all-inclusive rate. You get one rate for that patient encounter. Okay, that's what you're going to get. Now, based on one visit per day in most instances, somebody asked me about the word in most instances, and I just want to explain. If they come back to your FQHC and you could not have anticipated the reason they're coming back, it could give you an additional payment. The example, they were sick, so they came in and they had the flu. Then they were going home. You released them. You got them all good. Yep, got the flu. Do this, do this, do this. And they're on the way home and they fall and break their arm, but they came back to you because you were the closest place, or they fall and dislocate their arm. Guess what? That could be an additional payment. The diagnoses are incredibly different and you could not have anticipated one versus the other. So that's what we look at when we look at these. What other types of additional payments may happen? Mental health visits on the same day could be reimbursed separately, behavioral health. And then the FQHC can also have a hospice attending physician. Those services are not part of the FQHC prospective payment system. It is related to the hospice care. Therefore, if billed correctly, they would get an additional payment for that. Okay. And when we look at this prospective payment system, there are payment codes which can be given, and these codes then look at the 80% less of that versus the prospective payment rate, and which one do you get less of. So when you put all your payment codes together, you get everything on your claim. What's the dollar amount? Okay, we're going to take 80% less. Or is it less to give you the prospective payment system? And that's what we're going to look at when we look at these two types of things. In particular, though, we want to remind you that FQHCs, even though you're paid on an all-inclusive rate or, one rate, there are certain things that can make adjustments. One, geographical locations. Just like on the physician fee schedule, where are you located will adjust that. There are certain things like new patient services that will also make a difference. If you've never seen this patient before, we understand that it may take more work to get them set up and get them into the system and get them processed through. So that may make an additional payment. Also, there are certain types of preventive care, such as the annual wellness visit or the initial preventive physical exam that you can bill for, and they'll be separately payable. And telehealth. We already talked about mental health, but telehealth services is another example. Okay. Also, if an FQHC does a vaccine, it can be reimbursed under a reasonable cost versus their all-inclusive rate because it is a separate type of benefit. So it just really depends on a lot of those back and forth types of services and what gets separately reimbursable. But please remember, you must make sure everything gets put onto the claims. Next, I'd like to move into hospitals because hospitals have a variety of payment methodologies, and that's what we're going to talk about as we go through these different hospitals. So this set of slides is based in the hospitals, but it's going to be based in the different payment methodologies. Okay, so acute care hospital, long-term care hospital, inpatient psychiatric facility, and inpatient rehab facility are all types of prospective payment systems. And then the last one is reasonable cost, and we'll talk about that one last, as it does fall only to certain types of hospitals. Okay. So let's talk about the inpatient prospective payment system. This is an acute care hospital payment methodology. It is a per payment based on discharge diagnosis related payment. Okay, so keep in mind the key thing there is diagnosis related. What it does is when it looks at the prospective payment system, it takes into account all of the resources used and then gives you a daily rate based on that. This can be adjusted up or down based on yearly reviews. So your payment rate is set. It is paid based on discharge, One thing that people find interesting about this particular set of bundling rules is that it does include all care during the inpatient stay. So if you remember, I talked about the ambulance fee schedule, the clinical lab fee schedule, all of those types of fee schedules, all of them would then need to be billed to a hospital who would then have to incorporate it into the inpatient prospective payment system payment. Okay. But not only is it during the time that they're inpatient, if they have certain diagnostic and related services up to 72 hours before their admission, those services will also be included. This is sometimes called a 3-day payment window. So this is one payment given to a hospital. They have to pay for everything based on this payment. They are given a base rate, which does correspond to a diagnosis category. Then sorted by similar clinical conditions and procedures. What happened with the patient? Should you have comorbidity? Should you have other things which will make it go up or down based on additional diagnoses and other things that are happening? So it is estimated to have comparable associated costs. So that's the basis. It's an estimate of comparable associated costs. And again, you'll hear the term Medicare severity diagnosis related groups. That's exactly what this is talking about. Here's your base group. Okay, now with your base group, they have the following comorbidities, they have the following conditions, which are going to add those, make it go up, or it's going to make it go down based on what services you're expecting to use and what services you actually did use. This is a one and all done payment. So the payment does not base on the length of stay or anything like that. Okay. Now I said that and then I say, wait, but it does say length of stay, and that's an outlier stay. It's outlier additional payment. Something you're going to get because they were there an extra long time, but your basic stay is already built in. Okay. So when we do look at those types of things, you do have to incorporate into that. Now remember, part of your basic stay is the number of days they're there for. So that's why we have outlier stays. Outlier stays also look at the additional expenses that may be used and why are we there for longer periods of time. So it's kind of a per diem with some caveats added in. Additional payments, teaching facilities will receive an additional payment. You can also receive an additional payment if you have a low income beneficiaries. So there's a share of a certain percentage of low income beneficiaries. This can give you an additional payment, and there's certain quality and standards that you have to meet or exceed. If you don't, you can actually lose money or bring money up. It just depends. So you have to meet or exceed certain performance standards. So these do affect your DRG payments. Now, what will reduce your payments? If you have very high readmission rates. Now, higher readmission rates are higher than the national average, and so it's calculated. And why do they continue to come back to you? If conditions that are acquired during or because of this hospitalization. So if we look at the information and we find out, oh wait, they were inpatient for a period of time, they got this condition in your hospital and it's a repeat thing, it can actually affect your payment, can reduce it. Also, transfer of patients to certain other settings. This one can reduce it in terms of if they're going to a different hospital, if they're going to a long-term care hospital, there's an adjustment that can happen when they go to those long-term cares from those acute cares. So it depends on the settings that are happening, and you do have to report that on your claim and then make sure the adjustment occurs accurately there. Let's move on to the next payment methodology, which is actually the long-term care hospital. So this is again a prospective payment type system. It is based in the previous one, the inpatient prospective payment system, except it's added weight. The weight is then added because the patient is expected to be there for a longer time than normal. That longer time or that length of stay is expected to be 25 days or more. So once you reach that, then of course we can look at, okay, what else do we have to do? What are the different DRGs that we'll use, the diagnosis related groups? How does this affect the patient? And then what classifications can we put them into? Again, though, a long-term care hospital is based on discharge, and you'll be given a certain amount per day based on the actual items that were used. And again, that weighting system that reflects the different resources to make sure the patient is given. Each patient is grouped based on the same criteria. So we again look at diagnosis, secondary diagnosis, third, all of those different procedures performed, what happened during the stay, age, gender, and discharge status all affect this. If you do not meet the average length of stay, which again, 25 days or more, there is a payment reduction that can occur. Okay. So yep, we know that. So that's called a short stay outlier. So unlike an acute hospital or the inpatient prospective payment system, the long-term care hospitals have what's called a short stay outlier. It's considerably less than the average length of stay. We also do have to look at interrupted stays, and it's discharge and readmission to the same long-term within a fixed period of time. So you left, but you came back. Well, why did you leave? What's going on with that? What's happening with that? High cost outliers, and again, these outliers are things that you don't have in a typical case mix for that diagnosis, but they could be there, and those are things such as additional comorbidities, other types of situations that are going to cost more to care for that patient. Okay. And last, the failure to report your quality reporting. This will definitely bring down, we actually do have a negative adjustment that can happen if you don't report any quality measures. So There's also an inpatient psychiatric facility, which has its own separate MSDRG classification, a diagnosis classification. It is still based a little bit in the inpatient acute care, the same type of IPPS. So it is a PPS system, except because it's a mental health adjustment, there's reasons that they're looking for certain things to occur. So you still may have to treat certain comorbidities, which create secondary diagnoses and all those other things. Also with the inpatient psychiatric facility, the IPF adjustment, we do look for length of stay. How long are they there for? What are they there for? Again, what's the primary versus the secondary? What are all the adjustments? We also will look at whether they're located in a rural area. You can get additional money for that. So that may impact the hospital's payment. Do they have a qualified emergency department? They can perform certain services because they have that qualified emergency department. And if they're performing those emergency services, it is separately or could be a separate payment from their per diem or Prospective payments. Indirect medical education costs for teaching hospitals, and then additional for ECT treatments or stays with extremely high costs. Again, you're gonna see that one throughout, the extreme high costs or the outlier payments, because if you can't anticipate it, why should you be paid at that different rate? Okay. Which is gonna bring us to the next payment system, which is actually not about inpatient. It's actually gonna be about inpatient rehab facility first, before I get to the outpatient payments. So inpatient rehab facility is another form of an inpatient hospital based. However, because it's a type of rehab, they focus on certain things and certain types of information that of the needs of the patient. So for instance, yes, it's an MSDRG category. We've already talked about those diagnoses, but what are the patient characteristics and what are the key thing here? Intensity are needed. What resources are needed and how much of those are needed? What makes it that versus a skilled nursing facility where they could be having different levels of intensity, different amounts, which is why they're in the inpatient rehab facility. So we really have to look at those types of things. Part of the biggest payment portion is the patient assessment instrument. And what this does is it groups the primary conditions for admission. Really, when we look at the assessment instrument, it gives those information we need to know what's going on with that patient at admission. We look at the case mix groups, and these look at like functional motor scores, cognitive scores, age of patient. There's 4 tiers within each case mix group. So it's not just one case mix group, then there's a variety of tiers. And then it also looks again at those comorbidities. So when we look at the inpatient rehab facility, what you really have to look at for payment underneath this one is why they're needed in that type of a facility. And then what are the adjustments that could happen? Well, again, pretty standard adjustment, rural adjustment. If there's an interrupted stay, why? Less than 3 days. In other words, they thought they were going to be there, but they actually stayed for a very short period of time. Again, there's a percentage of low-income patients. Residency training stays with extraordinarily high costs. Again, we call those our outliers, and all of these different types will have that. And then again, you get a negative adjustment if you don't report your quality measures. That's inpatient rehab facilities. Okay, let's move on to the second to last one for hospitals, and this is the outpatient prospective payment system. This is used for outpatient acute care hospital payments. Outpatient acute care. It's individual services that are assigned by ambulatory payment classifications. They're based in clinical characteristics. So they look at things that work together. Outpatient rehab services. These are clinical characteristics, right? Then they look at geographic differences. Now, again, part of that is where is it physically located and should you get more money in a bigger city than in a smaller town, all of those types of things. The outpatient prospective payment system does look at packaged items or services, but one thing to keep in mind is it can also pay you per item or service based on what's happening with that. So what may be an ancillary or supportive item that goes into, or I guess for lack of a better word, bundles into a different payment, most payments are based on the primary service. Most payments are individually based without the packaging system. So if you do 3, 4, 5 services, you'll get paid more money than if you do 1 service. That's how the outpatient prospective payment system works. Also remember that they do look at things like integral part of another service so that you're not getting additional money. It has to be done in order to do this. That's an integral part. Let's see. Things that definitely can happen with an outpatient prospective payment system, new technology adjustments is definitely done. So I wanted to make people aware of that. Somebody asked a question about new technology and does it affect things? Absolutely. But it can pretty much affect any of these payment systems. The technologies can definitely do that. Okay. The outpatient prospective payment system does give you one base payment for everything, but it does have some different types of adjustments that can happen, and they have pass-through payments for specific biologicals and advice. So they also then offer, this is for new, they don't have enough data to set the actual payment amount, so they have this pass-through process, and we talked about the new stuff. Sorry, they do have outlier payments, and it's individual services that cost more. Just like an inpatient has the outlier, so does the outpatient. There's also adjustments for rural areas, and you'll see that a lot. And then there's reduction if they fail to report their quality measures. So they have a separate set of quality measures, and everyone has to report them, and you can get a reduction for that. The next one is the critical access hospital. This is your reasonable cost payments, and they are not set based in a certain amount. Instead, it's 101% of their reasonable cost. So they bill the charges, the actual costs are then looking at things, and we set them at 101% of the reasonable cost. So it's what's actually happening with that critical access hospital. Oops. Sorry, it's actually happening with that critical access hospital. However, they still have hospital bundling. Remember, this is for inpatient and outpatient. So if they're inpatient, hospital bundling still applies. You have to build a critical access hospital. They have to be able to check the services. So what types of things could happen? Diagnostic and related services would be part of that. If a critical access hospital sends someone for an MRI, that could still be part of that bundling package, including the ambulance run. So a variety of different things happen with critical access. The biggest difference is, though, it's a reasonable cost reimbursement versus an actual set prospective payment system. Rural health clinics, again, it's an all-inclusive rate. You get one rate, covers everything. Of course, there's some exceptions. Mental health visits on the same day can give you an additional. Second visit requiring further diagnosis and treatment. That's that one that we described earlier where you couldn't anticipate. They fell, they had something else happen, so they came back to the rural health clinic. And IPPE is a initial preventive physical exam. It's a preventive type care, but they would get an additional amount for that. Telehealth services. There are some things that they don't get directly reimbursed for, but due to a cost report, they would be able to kind of get reimbursed. And it's a different than a payment, like a physical payment. It's a write-off for them. So those would be things like flu, pneumococcal, COVID-19 shots, those types of things. However, they would get a direct reimbursement for a hospice attending physician service when billed correctly. So they actually will, again, file a cost report, and the cost report looks at the facility characteristics, the utilization data, cost and charges of the cost centers in total and for Medicare, and then the Medicare settlement data and the financial statement data. So it's going to look at all these different things. What its goal is to calculate all the different payments. So how much is your Medicare bad debt? How much is your pass-through rates? How much is your medical expenses, types of things like that. So if they fail to do this, they could actually get a reduction in payment. So lots going on with rural health clinics, and they're paid quite differently. But again, they do have an all-inclusive rate or a one and done payment. All right, let's move on to skilled nursing facilities. These facilities are paid again under a prospective payment system. It is different than inpatient prospective payment system or than any of the other ones we've talked about. Their payment system looks at what the patient needs. Why are they there for? Well, that makes sense. Are they there for PT, physical therapy? Are they there for nursing care? Are they there for non-therapy ancillary services, but still part of the nursing care? What's going on with this patient? And then based on that patient, they look at the services they have to have. So they give routine services, they give the ancillary and the facility costs for all of that. They combine it all together, and that gives you a per diem rate. Okay? So there's a variety of different things that can happen, but we do want to remind you that with the SNF prospective payment system, you still have to look at the quality reporting programs, and the value-based purchasing programs, and these can definitely affect the payment. So again, it is a prospective payment system. This one though does use a case mix indicator, and it looks at things like PT, it looks at things like OT and SLP and nursing. So what's going on with this patient, and considers all of those factors to give you a dollar amount. Okay. All right, so that brings me to the end of the actual the different payment methodologies, and you can hear a lot of different ones going on there. I want to see if we have any questions. All right.
Had trouble getting myself off mute there. Thank you, Tom, for all that great information. We do not have any questions in the chat this time.
Perfect. I do want to remind everyone, just a couple of quick resources, and then we'll close it out for the day. So the fee schedule websites are great. They're available for you. The reason that I put these in, and I'm not going to take you out to each one, is because each one has a certain set of pieces of information you'll need. So all fee schedules, that's the starting point. It's going to give you all the different breakdowns we went through, but it's going to give you a great starting point. If you're looking for some general information, I do recommend taking a look at that. If you're looking for fee schedule general information, would be like the physician fee schedule general information, things that are paid, ambulance fee schedules, those types of fee schedules, versus the prospective payment system general information. And those are the ones that we talked about, like the inpatient prospective payment system, the outpatient prospective payment system, the IRF, the IPF. All of those would fall into that general category, but I do think they're just great resources to have available to you. The Medicare Learning Network, if you haven't taken a look at the Medicare Learning Network, I will recommend that you do that. These are 4 things that I do find very helpful to help with fee schedules and to help with getting through that information. Along with that, I do have some information on our website. One of the big ones on our website is the fee schedules and reimbursement area. I'm going to show that to you briefly here. So on the WPS website, if you come in and you go to the topic center, I do have part A and part B. Part A is FIS, part B is MCS, part A is FIS, and part B is MCS. This is defined by CMS line of business. But if we go to the fees area, fees and reimbursement, it will give you first guides and resources, and you can scroll through and look at these. I'm going to open them up just by A to Z so you can kind of see the different articles that we have. And it'll talk about all the different fees and different things you might want to know, just so that you're aware. And then it's broken up by category. So one thing that I do like about the part B one, and this is because we do post the physician fee schedule, which is the dollar amounts directly to our website. That's what this is, or this is. And when you open it up, you're able to then download any of the physician fee schedules. You can see I downloaded Iowa this year. And it's just going to be a PDF document, but it's going to tell you all the stuff you need to know about the physician fee schedule. And again, it's done by procedure code, so you'd have to look up a procedure code. Also, one thing on here to note is this, where it actually says note. There are physician fee schedules which can be reduced, so the actual fee for the physician's office is more than in a facility because the facility is paid for that, and that's in that note section. All right, let's jump back. We don't have time, so I'm just going to keep going here. You guys didn't have any questions. So a couple of things to keep in mind. I am going to send you an email directly after this event. It's going to contain a certificate of achievement. Please take time to look through it. Don't just delete it. That certificate of achievement is on the bottom, and it's going to have contact hours. This is what translates to CEUs. We don't actually give you CEUs. That's up to a governing body. So please make sure you're aware of that. It'll also give you an opportunity to take the survey or to provide feedback. We want to make sure you do that. If you do have follow-up questions and you want to know a little bit more, something that I didn't get into, please feel free to email those to me. You have 7 days to do those. Here's the information for that. Please make sure you follow the information given in the chat. Again, just looking for payment method webinars so that we can get that correctly to us. Let's take our survey. Provide us with that feedback. I think this is really important. Again, as we talked about with new to Medicare, the feedback, the information that you're giving us is what helps build the new to Medicare program and what are you looking for. So please make sure that you're taking the survey. You can do that right now. Click on the link in the chat. Awesome. You can wait, and we're going to give you a pop-up box. It's going to look like the lower picture. It'll say external website. This is a redirect after we close. And last, I'm even going to give you a link during the encore presentation. And it's going to look like the upper picture. It says online survey. So we're going to give you a variety of information or opportunities to give us that feedback. It is very important to us. We really like your feedback. All right, so that brings me to the end. Thanks for listening today. I hope you did get something out of it. I hope that you give me the feedback so that I know what you liked, what you didn't like, or what I need to improve on. Please remember to incorporate any topics that you want, whether they're new to Medicare related or not, into that survey. It's a great opportunity. So on behalf of myself, Aline, and all of Provider Outreach and Education, thanks for participating. We look forward to your survey comments, and we hope that you'll join us again in the future. You may now disconnect.